Hi, good evening to everybody. Um, Thank you all for joining us for this discussion about COVID-19 and how it relates to laryngology, with the caveat, of course, that this is what we know as of today, right? And as we all know, this is continuing to evolve and change over time. I just want to say thank you to everybody for being here. I know we've got a lot of interest in this topic. I'm sure there's going to be lots of questions, and that's part of the reason why we decided to put together this session to talk about that. The topic of the day is about COVID-19 and laryngology. I optimistically would love to think a bit more about laryngology in the time of COVID-19. It sounds nicer. But I wanted to take a second to introduce myself. I'm VyVy Young from UCSF, and also to introduce to you our panelists, all of who you know, I'm sure. Milan from NYU, Dr. Lucian Sulica from Cornell. David Chang is joining us from the University of Missouri, but especially in his role as chair of the Academy's PSQI committee. And hiding in the background is going to be Dr. Michael Johns from USC, who's going to be serving a special role tonight for our webinar in terms of curating all the questions that we hope that you guys will be garnering out there. After our test drive last night, everybody was a little concerned about my choice of masks, so I upgraded all of us. And if I say nothing else, it's probably my sincerest hope for everyone that you all can have N95s like that. Would be great for all. Disclaimer up front, none of us are COVID-19 experts, but we are all rapidly becoming COVID-19 experts. And the idea of our session tonight really is to start a discussion amongst all of us about COVID-19 and how it relates to us in the field of laryngology. The idea is for this to be a discussion for obvious reasons with 500 participants perhaps. We can't have everybody speaking, but we do want to allow for an exchange of ideas. So we've specifically formatted our session tonight to be sort of broad and loose with lots of time for discussion and interchanging of ideas. Please use the Q&A function to ask your questions. I believe that you can also answer other people's questions, although we are going to try to address that in our group here. Michael Johns is going to be sort of reviewing these and curating them for themes. And hopefully we'll have a lot of time during our session today to go over all of this. And ultimately, the idea is to share what our experiences are in our individual institutions in hopes of sort of understanding what the lay of the land is, maybe get some good working ideas from each other, even if it's just to commiserate over where we all are, and hopefully help each other as we all have to during this time. So I think the elephant in the room that we all have to talk about first and foremost is going to be the whole question of office procedures. The big elephant, of course, is going to be laryngoscopy. And so I guess I would start with asking Lucian. I mean, we all know, we hear in the news about things really have ramped up in New York. Can you give us a sense of what the situation is, and has this changed even further what you guys are doing in terms of scoping people?
Well, I mean, the situation has just changed dramatically in the last week or so. And I have to tell you that the #1 priority now has shifted to preserving resources. And, you know, we used to worry a lot about spread, and now the dominant message that we're getting is conserve PPE, conserve PPE, conserve PPE.
So has that changed even further, the criteria?
Absolutely.
For public scopes?
Absolutely.
Yeah.
So the operative principles here are you don't do any procedure that can be avoided, any laryngoscopy that can be avoided, anything that you can identify with ultrasonography, radiography, some other way of doing it, do that. Okay. When somebody does any procedure, it should be the fewest number of people, which is plainly an equipment preservation issue, right? And it should be the senior-most person. So, for example, when there's a trach change to be done, as happened this weekend on a patient under investigation in the hospital, the person who went in was the attending and only the attending. Mm-hmm. And that's very different from how we were thinking about this 7 to 10 days ago.
Milan, is it NYU?
Yeah, no, it's exactly the same. I think what we've done is pretty similar to what Lucian's saying. We've essentially converted everybody to virtual visits, and we are screening heavily to the point where, you know, I may be only seeing 4 patients in a week, and all of those patients are airway patients or something critical that we can't have another, there's no other means to look at them or to evaluate them. And, you know, we are practicing, we have our N95 mask in the office. We've created these little kits with gowns, and I have a face shield. And if I have to do a laryngoscopy, I do it that way. We move so I have a box in the room. So as soon as the laryngoscopy is done, I dump the scope in the box, take off my gloves, close the box, take it out of the room, and hand it to the MA, and then she processes the scope that way. We try to conserve room, so we have one room specifically designated that day for laryngoscopy, so the other rooms are not contaminated, and then we'll swap for the other room a different day if we need it. But I agree with Lucian, it's really more about preserving equipment, and so we're reusing masks, we're reusing, probably not gowns so much, or gloves, but we're using masks and face shields to just preserve them.
Are you all able to hang on to your own, and like you're in charge of keeping your own mask in a bag, or is that something that's institutionally, like they take it and then they re-sterilize or process it somehow?
No, so in the OR, they hand us one mask and a face shield or something of that sort in a paper bag with your name on it. And you use it as much as you can throughout the day, unless it gets soiled, and they'll give you another one. But you know, the reality is I did 3 cases, 2 airway cases in one, a case of a patient who was losing weight and had cricopharyngeal achalasia. And the full time that I had the mask on in those cases probably added together probably about just over an hour. And so I put the mask back in the bag, left it in my locker, and the next time I go to the OR, I'll perhaps use it again.
Mm-hmm.
That's right. And that's not just the N95 mask. We were issued a surgical mask that we were instructed to wear anytime we went to the hospital. And we were told that that's it. There would not be another mask.
That's for OR cases, or if patients you see in
Oh,
everything?
that's for if we have to go to the hospital to see consults, even, I mean, non-COVID consults. Just doing our usual on-call otolaryngology stuff.
Right, not cases where you would worry about the spread through aerosolization, essentially.
Presumption in New York is that there has been widespread community transmission. So everyone is presumed exposed. At the end of last week, they lifted quarantine from healthcare providers. They said, even if you have a known exposure to a COVID-19 patient, you come to work unless you have a fever. Okay, so none of this 2-week stuff. It was taking too many people offline. And, you know, we do have absolutely unrestricted community transmission in New York, thanks to the lack of early testing. So that sort of informs all these decisions. You're presumed contagious, you're presumed exposed, and we're just trying to limit the spread to from spreading to vulnerable individuals.
Question?
Okay. Oh, yes, Michael.
A related question is that, so in your situation right now, given the resources that you have, are you using N95 masks for all patients or just the known COVID positive patients?
For me, it's just when in the office, for example, if I have to see a patient that I'm concerned about specifically respiratory aerosolization, so patients all scope, patients with trachs, things like that. If I'm not going to scope that patient, which is again a rarity in my practice at this point, but then I would just wear the regular mask with a sheet on it.
Yeah, you know, I've read, I mean, same here. I've read that every now and again that diagnostic laryngoscopy has sort of been designated non-aerosolizing, usually by someone who doesn't do laryngoscopy. you know, if your patient coughs during laryngoscopy, that's aerosolizing as far as I'm concerned, and my patients occasionally do cough. So that's an N95 procedure, and not just N95, but full PPE.
So one wonders whether, I don't know if you guys instituted having your patients wear a mask too to help prevent that aspect. And I think that would be a very helpful component too. Again, when we talk about conservation of PPE and resources that may be limited, that may or may not be feasible. And the other thing I would have you think of is, you know, obviously we're in this time where we're wondering whether we really need to have some of these patients in our clinics. What's the necessity of having to do the scope to begin with? I'm not saying that there isn't an issue in where scopes should be done, but one needs to wonder, what's the acuity of the issue? Can I reasonably infer what's going on and or initiate therapy without knowing exactly what's going on in there? I know it's a little bit anathematic to kind of our culture, our specialty, in which we have all these tools that are available to be used. But in this kind of era, maybe we need to think about how we triage or how we work these patients up a little bit differently. You know, one of my colleagues had mentioned to me, you know, if you strip me of flexible laryngoscopy in the clinic, you've taken away my tool to utilize to be able to do any of what I do. And I said, well, you know what? You can start a therapeutic relationship. You can talk to the patient about their problem, and you can kind of at least guide them along the way. And I think that will help a whole lot for, you know, obviously kind of more benign functional kind of things, as opposed to if you're worried about carcinoma in situ or other more malignancies.
Well, David, you know, that's a valid point, but I think in laryngology, you really are restricted to practicing your subspecialty if you can't see the vocal folds. And I think, you know, I would emphasize the acuity part of what you've proposed here. The big question is not, does the patient need to be scoped? Because almost certainly the answer is yes. The question is, does the patient need to be scoped this week? Can it wait a month? Can it wait 60 days? You know, until the equipment shortages have been made up, hopefully.
Yeah, and I agree to some degree as well that there is a certain, and that determination has to be done on a face-to-face basis with the patient. And I think actually I've been pretty impressed with the ability of these virtual visits to actually allow you to do that. You know, I was sort of skeptical in the beginning, like, how am I supposed to see a new patient and really come up with a plan with them? But it is reasonable. The video visits are actually quite nicely done. And patients are very understanding when you explain to them that you're treating them empirically. It's going pretty well, I think.
And how much do you feel like you can make that clinical judgment?
Well, I think with a lot of our patients, I can make that clinical judgment. You know, you're not going to diagnose what lesion they have, but you can do a certain risk assessment. You know, if you have an 80-year-old male who has some hoarseness, you know, you're not going to know whether that's a cancer or presby, but you can certainly put that off for a few weeks, knowing that most likely that's, you know, that larynx is going to be presbylarynx, and you're going to be able to scope them in a few weeks. But there are patients, for example, I had a patient who had, quote unquote, sent to me with a, you know, quote unquote, voice disorder, and he had dysarthria. And I was able to certainly weed that out, note that I probably didn't have to scope him, and that he needed to go back to his neurologist for a full assessment. So there are things that you can certainly do short of scoping people. And I think, you know, there are going to be some patients I have to see, and the vast majority that I don't have to see right away.
Are any of you guys using disposable scopes for, you know, decreasing risk of contamination when, like, Milan, you hand off your scope to the MA, but that has to be transported to SPD, other people handle it, et cetera, et cetera. Is anybody looking at or using disposable scopes to at least take that aspect out of the equation for potential transmission?
So we did that with our residents. We are just not set up to do that in our office setting. You need the monitors, and you need the system that goes along with it. You know, we clean our scopes in our office, so it's not like they're transported to SPD. Mm-hmm. For the residents, that's what we did. We secured a bunch of disposable scopes for them, and so that's what they're doing currently.
David, is there any interest or word from the academy in terms of whether that's something that could be useful, or are there other, I know we're all seeing the emails that are coming out with some of the academy's work and setting up guidelines. Are you privy to other things that are coming down the pipeline?
So I haven't really heard a whole lot of chatter necessarily about disposable scopes. I think that obviously the economics of it don't really work out very well. We've looked at it at the University of Missouri, again, mostly for our residents in terms of consultations. It enables us to share the video a little bit better, or share images a little bit better with the attendings. And so they don't necessarily have to be real time in there with the scope procedure itself. But from a cost perspective, it's pretty costly. You know, if we did, you certainly wouldn't want to do a high volume clinic and throw away $150, which is, you know, $150 to $170 is about what our hospital was getting charged for each AMBU flexible laryngoscopy scope. And so it's just not a very palatable kind of thing. But certainly in this era, we may need to think differently. Obviously, the economics of this whole thing are throwing everything upside down. And so depending upon your resources available and what you have in your institution, this can be one way to hopefully try to prevent spread. But you know, how much of the spread is from fomites and how much the spread is from the actual aerosolization is kind of hard to know. You know, one thinks that some of the stuff that came out of China, whether it was the sinus procedures, the pituitary procedures, or some of these laryngoscopies, how much of it was just sort of the way, the old school way that we used to handle airway secretions. In other words, you know, the CDC recommends that you use a mask whenever you are in potential jeopardy of contacting aerosolized secretions. But how many of us actually wore a mask doing flexible laryngoscopy in the pre-COVID era? I would venture to say none of us did. With that guidance in mind, should we have? And with that guidance in mind, are we going to, after this COVID wave goes away? It's a good question.
Milan, can I circle back to something, to a comment you had made earlier, and also the patient you were talking about? I want to ask you specifically about how you're managing your dysphagia patients at this time, or more importantly, your new referrals for dysphagia, right? These are not people that you've seen, that you've established, you know what's going on with them, but at this time when we're limited, right, where you can't really get a FEES or an MBS, how are you triaging these people? How do you decide what can be done or should be done with them?
Yeah, I mean, I think I'm somewhat fortunate in that we really haven't had a situation where I have had to make this decision in the short run. I have some patients that we're sort of managing that I know already, but as far as new referrals for dysphagia, I'm not really seeing them right now. I mean, I think everything's really shutting down to the point where people are not even, you know, seeing patients as in the outpatient side, so we're not really getting those referrals in right now. But we've had discussions about this because, about 10 days ago or so, radiology basically shut down MBSs and also pretty much all other scanning procedures unless they were urgent or emergent. And obviously fees we've talked about as being the backup for that. But you know, if we were going to do it, we had talked about essentially switching these patients to having fees and using, you know, full PPE for that. So I think we haven't had to deal with it exactly, but that's what our plan was.
You know, I wonder, you know, David, you're taking this like big picture view about how our era is changing, but I wonder if people outside of New York really understand, Milan, how this town has shut down medically, waiting for the tidal wave to hit.
Yeah.
I mean,
do you think that it has hit yet?
No.
Yeah.
No,
Still coming.
not anywhere close. I think people still don't really understand how bad this is going to get.
I believe you're right. Certainly here in the Midwest, where I'm in central Missouri, Columbia, Missouri is halfway in between St. Louis and Kansas City. We only have, I think, about 10 community cases or 10 cases within our county. For a long time, I think, you know, we intellectually know it, but we don't really viscerally know it. I guess it's kind of like, you know you should diet and exercise, but until that day comes when you realize you have to fit in that wedding suit, that you don't start dieting until the day before, it's a little too late. I think it's hard. I guess it's kind of like the concepts of global warming and, you know, whatever you can put off, we can want to try to put off.
So let me give you a little bit of color here so you understand how we're thinking, right? On Thursday, the governor signed an order saying that if we're credentialed at any New York State hospital, we are now credentialed at all New York hospitals. We've been told that our job descriptions no longer apply. And on Friday, we got the 24-hour warning for redeployment. Okay, we may be redeployed outside of our hospital. We may be redeployed outside of our health system.
To fields that we don't deal with.
Our projections are that at current capacity, we will run out of ventilators on Friday. Okay, now obviously we're ramping up capacity, so that won't happen for a little while longer. But we're going to run out of ventilators. It's very, very clear we're not going to be able to keep up with it at the rate that it's spreading.
Yeah, I mean, we've certainly, even when talking about surgeries, we've gotten to the point where we, you know, essentially have put off cancer surgeries at this point. It's only, you know, bleeding, airway obstruction, and things along the really emergent screen that we can do. And I'm, as service chief, I'm actually fed all of the cases, and I have to approve them to go through or not, based upon those recommendations.
Right. So, you know, we are starting to turn the corner to talk about surgeries, and I definitely think that's our next big topic of discussion. I definitely wanted to make sure I circled back to Michael to see if there were any high priority themes that are coming out of the Q&A that you wanted to bring forth.
There's a number of questions related to surgery if we're going to get to. There was a specific question regarding we're following up with Milan's question about the value of televisits for speech pathologists getting new referrals to initiate therapy when best practice typically would require a scope. What would be your recommendation as to how to proceed?
We are actually going to get to telemedicine also, but we can address that now if that's better too. Go ahead.
No, I think I think we have to think outside the box here. You know, not to say that we are prioritizing speech language pathology visits here. I mean, we're really talking about trying to limit and redeploy people into areas that they're needed. But you know, we do have speech pathologists who are basically sitting around doing nothing else. That we've converted all these to video visits. And if we happen to have a patient who we can't scope, we're just making an empiric decision that they're going to do voice therapy for a while. Nothing bad's going to happen. You're not going to hurt the person. Is it 100% necessary? No, absolutely not. But if the speech pathologists want to see patients and prevent the backlog that's going to happen as soon as we get out of this, it's not unreasonable, I think, to have them see these patients.
I think speech pathologists have a really valuable role here in continuing to make our patients feel supported at a time that the MDs are probably going to be pulled from any type of outpatient care. I'm actually really interested. We haven't started doing teletherapy, but I'm really interested in doing that simply to help our patients still feel like somebody's looking after their problem at a time when a lot of medical direction is directed elsewhere.
One last question.
Michael, 1 second. I was just a comment quickly if I can. I was actually just talking about this with Sarah today, and I think that the continuation of a multidisciplinary assessment as best as we can provide for patients, I think is critical. And we were discussing how even if we send our patients to the speech pathologist for even just an initial assessment, right? They can listen to the patient's voice, they can assess their stimulability, they can assess their motivation to pursue any further treatment, I think can go a long way to, as Lucian says, keeping us connected with these patients, keeping us engaged and let them know that we are interested in their well-being, but also maybe to help us really select out the people that can be best helped during this time and in this way. I think it's really important. I do. And then Michael, you had another question.
A rapid rundown, top 3 reasons to scope a patient. We're talking about the throat.
Acute airway distress, airway bleeding. Those are the two reasons.
I think strong concern of malignancy.
Fair enough.
David?
I think those are fair, and I'm sure Lucian picked those first two because your resources are getting stretched thinner. But certainly in places that haven't yet hit their, strong aspects of, suspicion of malignancy, something that's going to change what you can do or want to do in the 4-week time frame, depending upon what your time frame allowance is in the hospital. So.
Save your PPE. You're going to need it. You're going to need it.
Yeah.
I don't care if you have no cases in your town right now. You're going to need it.
Yeah. Okay. So next topic, what we were saying that we were going to get to is going to be about surgery. And, the PPE conversation does carry over here too, right? Because when we talk about surgeries in the airway, whether it's tracheostomy or airway stenosis surgeries, which are probably the two most urgent topics of discussion for today, those are aerosolizing procedures. And then the question becomes, how are we approaching this? Obviously, the traditional guidelines that we've all followed with performing a tracheostomy in such and such time frame is sort of out the window. How are your institutions addressing tracheostomy? Is it a case-by-case basis? Are they uniformly being pushed back? There's a whole host of things to consider, right? Where are trachs being done? Open versus percutaneous approaches. There's a lot of things to consider, and I just wondered, maybe David, if you would speak about, have you seen changes in Missouri since you guys are not seeing so much in terms of community cases and things like that? Is it still sort of?
So right now, we haven't been as draconian yet in terms of limiting surgeries that aren't necessary or that aren't needed. That are needed. So we're moving forward on kind of all the necessary types of stuff. I would love to hear how it is in New York, but
Yeah.
I'll just kind of give the overview of the talk, and I'll let our experts who are neck deep into this chime in. So the thoughts are open versus percutaneous. The open proponents say that you can have the patient paralyzed, that you can hold the respirations, and so when you do the trach changeover, that there's no stuff that gets sprayed into the air. The proponents for the percutaneous say, well, it's kind of pseudo-closed and you can kind of dilate and go into there. The problem with that is, are you going to use a rigid bronchoscope, which then allows things to spew into the air, or are you going to use a flexible bronchoscope in which you still have to bring back the ET tube a little bit and there's still less competence? Late versus early, the controversy is, late, you're going to do late anyway, maybe because the morbidity and mortality is so high in these patients that they're not going to be ready to get off the ventilator. And so what are you saving? I guess the only argument for early I've heard in some places is to consider early if it changes your resource allocation. And I'm not sure in what scenarios it might change your resource allocation, but let me defer it to our East Coast people to chime in what they're doing.
Milan, do you want to go first?
Sure, yeah. So there's a lot of chatter about this in our institution. Interestingly enough, we actually haven't come up on this situation of tracheing a COVID patient just yet. Largely because, the mortality is pretty high. So our initial thought was just push it as far as possible. And as I said, we haven't really even encountered one positive patient that needed a trach just yet. Over at Bellevue, our sister institution, we've had 3 requests for trachs, all of non-COVID type patients. It's a totally evolving situation. I think when we first encountered this, our initial knee-jerk reaction was absolutely not, we're not tracheing any COVID patients. The administration sort of pushed back on the resource issue. And I think that they felt very strongly that we should be available to do trachs when needed. As I said, the reality of the situation is that the volume as of yet has not really been there. So we haven't had to deal with it per se, although we've come up with formal guidelines as to what we would do, which is on a case-by-case basis. We'll have a discussion. We are currently discussing the issue of testing prior to, and I know that some institutions have instituted testing prior to doing trachs. Again, as Lucian pointed out, testing is a resource, and we are starting to hit the issue testing resources as well. And so there's some pushback from administration that we may not be able to test everybody either. So we're working through that. I think right now we're willing to do trachs when necessary if it's going to help resources.
When it comes time for you to do it, are you going to do it with an N95 if it's available? Would you do it with a PAPR? What's your plan?
Yeah, again, I think the PAPR issue is a resource issue. I think we have 60 PAPRs in our institution. And I don't know that if we start using them for everybody that needs to be in the room, we can do maybe 5 trachs. So I don't think we'll be able to use PAPR, but certainly face masks, N95s, gowns, gloves, the whole deal.
Lucian?
Yeah. Well, so I mean, I think, when people look and see that New York has 21,000 cases, people don't realize, first of all, how quick the ramp up is. And these issues that you think about when your case count is going from 4 to 8, 14, go by the wayside when you go from 500 cases 10 days ago to 21,000 cases today. It's still a relatively young infection. So like Milan, we haven't really hit people running up against their intubation, their trach time, because they've been for prolonged intubation. There was a lot of good discussion of this in a town hall meeting that Stanford ran on Friday, I think. That's totally worth watching if you can spare the time. The feeling has been that either these patients get off the vent or they die. And the need for trach is not nearly what it would be in a similar number of patients who were in the ICU for some other reason, that you would trach at the 7 to 10 day window. The other aspect of this is there are so many short-term conservation issues coming up that you don't want to waste resources. So I think patients are going to stay intubated for a very, very long time before they get trached.
Yeah, I had correspondence with some of our Chinese colleagues who had put out a small little paper about otolaryngology preparations and their experience. And some email conversations I had exactly mirrored that aspect, is that I asked them, well, what's your trach timing? He said, well, you know what? The reality is that we hardly ever trached anybody under 2 weeks because they weren't even ready to come off the vent. And that the natural course of it was that, by the time that they were at beyond 2 weeks, their thought was that a lot of the viral load was down. I know that's an evolving component as well too, is how long does the viral load stay there? Is there potential for viral load resurgence? But their thought was, the viral load is down at a 2 weeks and you're not at as greater a risk. Now they still recommended an N95 and a PAPR or a capper during the tracheostomy. And then also they recommended afterwards, if they're ready to wean off the vent, to put a viral filter as well as a little humidification chamber, which has kind of a baffling system there to be this dual viral particle filter out into the air. Okay,
so if trach is potentially not really going to be a big issue for us, for better or for worse, how about airway surgery though? Because those don't follow the rules, right? Airway stenosis patients don't know there's a pandemic going on. When they have stenosis and they get stridorous and they need us to intervene, they're still going to come in. So how are you guys, Lucian and Milan, how are you guys addressing patients that have known subglottic stenosis, for example?
Stridulous.
Do you try to get them in when they're only moderately bad before they completely tank and it becomes an emergency and a disaster? Or do you push them out as long as possible, hoping that we're past the surge or that we're, at that right time, between okay and disaster?
So I think the answer is yes to both of those. Ultimately, it's a case-by-case basis. So last week I did 2 airway cases. One absolutely 100% needed to be done right then. And the other one probably could have waited about 2 to 3 weeks. But last week was a different situation than this week, because last week we had the resources to get that case done. And I was concerned that in 2 to 3 weeks, we would not have the resources to get the case done. And in fact, on Sunday, our administration shut down any non-emergent cases. And so she would not have qualified this week or next week for that surgery. So I'm glad we got her done. I have
Did you
another case.
do, oh, sorry, go ahead.
I have another case coming up that absolutely has to be done, and so she will get done. And then I have another case that probably can wait a couple of months, and that will get pushed a couple of months at this point.
Are you doing the same thing that you usually do in these surgeries? Or are you just like shortening things, you know, a quick procedure, dilate and get out as quick as possible? Or do you still do the whole, whatever your normal routine would be for these patients?
Yeah, I'm doing the case, and I'm not having the residents do anything, or maybe perhaps the fellow, but I'm talking to them about, you know, just get it done ASAP. Don't waste time. No futzing around with these cases. But I have to do them the same way I do them.
Are you even having them in the room, Milan?
So we allow one resident in the room, and currently it should be the most senior person at current with the recommendation. I probably don't even need that, to be honest. And starting probably in the next few weeks, I won't even have that.
Lucian, are you doing anything different, or do you have anything to add?
No, I would limit it at this point. I think we're all limited to emergencies, and I haven't had any of these cases like Milan has in the last couple of weeks, so I've been fortunate.
Michael, you said that there were some questions related to surgery.
I think we've covered most of them. Any special considerations for jet ventilation for airway stenosis?
Yeah, for us, yeah, we think about it, obviously, and it's a big concern, and we talk about it ahead of time, but the practicality of it is there's not really an easier way to go about this, especially in patients who have really, really narrowed airways. So we just deal with it, and obviously we have to make sure we're wearing face masks. So we can actually, interesting enough, it's actually to protect our N95s so that we can reuse them later.
Yeah. And you can't use a PAPR with the microscope. So that also.
Well, we did use more microscope also to keep us more separate from where the air was coming out. And so that, you know, just a consideration, keep you further away.
One other consideration in places that have learners, I know this is a tough time. How do we balance out the safety of learners versus also their educational experience? Is that if you're doing it under the scope, try to record them as much as possible, and so that you can share the experience with your learner in a non-OR setting.
Do you guys think with jet ventilation that there's any difference between like a supraglottic jet versus something like a Hunsaker that just pushes it further down and away from you? Do you think that makes a difference, or is it just the fact that you're in an open airway, like an uncontrolled, you know, airway situation, that it may not make a difference? Or do you think it might?
I can't see how it would make any difference. I'm not sure.
Yeah. I wasn't sure either. Okay.
Yeah.
Michael, anything else from folks out there?
There's a comment that Thrive may be more likely to aerosolize the high flow mechanisms. Apnea would be a consideration. Thanks to all the community answering each other's questions. There's many happening. This is just a lively discussion. Press on.
Yes, thank you everybody for being active participants in this. Is anybody doing any kind of nebulized lidocaine or anything like that in the office, or is that just completely out at this time?
Out.
Yeah, no, it's out. Again, as Lucian said, I think that the volume is so far down at this point that, you know, it's to the point where the last time I did this, I wasn't thinking the same way. And now this week, we're going to change that recommendation and we're not going to do any aerosolized sprays.
Right.
Agreed.
Yeah, makes sense. All right, let's talk about redeployment. Lucian, you referenced this being something that's maybe looming on the horizon. I know there's been some other people I know from other institutions where they're starting to hear some rumblings of this as well. Have any of you guys been, you know, told explicitly that you're going to be pulled to another department, another unit, a different hospital, or even just asked to be part of a specific intubation team? I haven't heard anything about that at UCSF, but I didn't know what the experience at other institutions might be.
Lucian, you may want to speak because I know that for Cornell, they're sort of ahead of us on this particular issue.
Not really. The big demand has been for people with an ICU background. So there was some activity over the weekend looking for people with ICU background. Obviously, that doesn't include most of us. Regarding intubation, they have a surplus of anesthesiologists right now because we're not doing any surgeries. So we're not being called upon for that. And what we have been told is to expect to function outside of specialty. So again, I'm not sure that we're going to be able to sort of be picky enough to use people for their skills other than ICU skills, which are very highly sought after.
So I'm just going to tell you our experience. So we got an email over the weekend asking for volunteers to serve 12-hour shifts on a medicine floor. It's not a mandate by any means, but they're asking for volunteers anywhere who feel comfortable doing medicine floors. I know that, so my wife is a pediatrician over at Cornell. So in the pediatrics department, they sent an email out this weekend mandating that every single pediatrician respond as to whether or not, why they could not cross-cover other folks that were pulled. And if they didn't respond, they would assume that they could.
Right, that's true.
They're creating a list basically of people, and they're not doing anything just yet, but I think they're just preparing essentially when some people get pulled from the ICU, who backfills them, and then who backfills them, that kind of protocol, which makes a lot of sense at this point.
Yeah, and the questionnaire is one of these things that you don't think about that much. It was, do you have any underlying medical conditions that would make you a high-risk person in a COVID environment? If you do speak up, if we don't hear from you, we're going to assume you're okay to redeploy into that environment.
And nurses certainly are being asked that same thing as well, too, the nursing staff. At the University of Missouri, we are part of the airway team, I'm sorry. I talked with the anesthesiologists, and they have this grand plan. I have not actually reviewed their plan from an airway perspective, but we are part of that airway plan.
So David, with this talk of having to cross-cover other specialties even, or other areas that we are, that information may be tucked way back in the back of some dusty drawer corner of my brain. I wonder if the Academy has any thought about resources to bring the average otolaryngologist back up to speed with some common topics or common issues that we may be asked to help to manage?
That's a good thought. We have not gone that far. I would imagine that hopefully they would try to utilize our skills for what we can do. If they certainly need bodies just to help facilitate things, we'll probably be at a lower level of our ability to kind of help from a technical or knowledgeable perspective. But I will feed that back to the Academy and see if we can also start getting some of those resources. I think we're going to be, once it comes to ICU kind of care, we're going to be really putting the weight of that based upon our internal medicine and ICU folks to help with that.
That's right.
I believe that there may be information on the Academy's website from CCM, the Critical Care Medicine Society. So maybe that would be something that could be potentially of help. I'm getting that message from Al.
They are, by the way. Each university has their own internal trainers as well. So if they're putting people in situations where they're not so comfortable, they have people training them up essentially to do that job as well.
Great. Okay. One last big topic that I had in mind was about just sort of how we are managing our practices during this time that we essentially kind of don't have a practice anymore, right? And how do we stay in touch with our patients? How do we keep tabs on some of these people? Obviously, that brings up the whole question about the role of telemedicine. I know that there are places that aren't doing anything at all. There are places that are already up and running. I know that a lot of our speech pathology colleagues have experience doing teletherapy. And I just wonder if any of you guys are using telemedicine visits. And Milan, you said you were starting that. You know, what kind of roadblocks have you come across in getting this up and started, or what advice can you give to other people who are just looking to get started with this?
Well, I mean, I think we're fortunate in that we're at universities, and the universities have essentially taken care of this. I mean, you know, our place has been talking about this for over a year and a half, and really hadn't gotten very far. And literally in 3 days, they put the entire thing together, including negotiations with insurance companies. And so now they're pushing this because obviously they're hurting by not having any outpatient surgeries and outpatient visits. And so now the hope is that they're going to at least make some of the money on telemedicine. As I said, you know, I've now done, I think, about 7 or 8 telemedicine visits. I have another maybe 10 to 15 this week. It's actually not bad. The build out in Epic is quite slick. You know, you go onto your chart. The patient can arrive themselves, and then they are just sitting there in a virtual waiting room. And when you're ready, you click on the icon and you push that visit to an iPad or your iPhone, and then you can actually do the face-to-face on that. And then when you're done, you hang up and you go back and you document your visit. It's quite slick. It works really well. We've had some technical issues, of course, because again, they built it out in 3 days, but it's working itself out.
What do you say to the patients that are like, Dr. Amin, I have no idea what this visit is about because you can't even look at my vocal cords anyway?
They don't say that, actually. It's been amazing.
Oh, really?
The patients are very, very much understanding of the situation, and they're very just excited to be able to have a visit with a physician because they know that they just don't have that access otherwise.
The other thing that's driven it, besides the not inconsiderable financial aspect, is the hospital desperately wants to keep people out of the emergency room and really kind of wants to keep people out of the outpatient offices too. So yeah, we've seen the same thing. We've been mucking around with this for more than a year, and suddenly over the course of a week, everything that was not possible is suddenly done.
Yeah.
So for those of you that don't have the backing of a huge enterprise to help you with this, you know, the laws have changed, if you haven't really realized it, and the Academy has a great link to tell you about the law changes, but the law changes have temporarily changed to allow you to really utilize technology that really wasn't typically encountered for video visits. And you can use something as easy as FaceTime. Here we're on Zoom. You can use Zoom as well too. And so these are technologies that really are at everybody's disposal that you can utilize. Yes, it may not slickly integrate into your EMR, but you don't have to be under the bowels of this huge enterprise to help you do telemedicine visits.
Mm-hmm.
Just chiming in here, the HIPAA requirements have been waived for all of that, including telephone.
Yeah, so the HIPAA requirements aren't as strict. The requirements as to like who initiates and what areas that you can talk about, or if you're in a resource poor area, those have all been waived as a result of this. Now, again, this is from the federal government doing this, so it's waived for Medicare, but hopefully the third-party players are going to certainly follow suit if the government really puts the screws down on them to say you need to shape up too.
Mm-hmm. Michael, other topics or?
Well, can I just add one point
yes.
to this, actually, because
Sure.
This just came up this past week because I actually happened to be on call. The person who was on call actually contracted COVID, and so I took his call for him. And I think this is actually an interesting situation too, because clearly on call, we're going to encounter situations in which we need to actually see these patients. And certainly a telemedicine visit is not going to cut it, and a phone call is not going to cut it. So I had 2 particular patients, one with an epistaxis that wasn't stopping, and another one with a potential CSF leak after a skull base surgery earlier in the week. And so it's sort of interesting because, as Lucian said, you don't want to send these patients to the emergency room because they're overburdened as it is. And patients certainly don't want to go to the emergency room. They're they don't want to get exposed. So I was discussing it with our administration, and they've cordoned off a portion of the ED that's just respiratory, and another part that supposedly is not. Even with that, I think we as a faculty and our patients don't feel comfortable with that. So we've talked about actually setting up our own sort of internal urgent care, having one of the offices open 24/7, and just directing patients that we need to see urgently to that site. And our residents perhaps can meet us there and bring equipment, and if we need that specifically. So it's an interesting sort of side practice management issue, but it's important to think about.
That's interesting. The OBGYNs at our institution were set up the first arrangement where they are in direct contact with the ED. And like a lot of other hospitals, the ED is now preceded by a triage tent.
Yeah.
Because they're trying to keep everybody who doesn't have COVID or likely COVID from going into the emergency room. Right? So now these patients who have OBGYN issues actually get shunted across the street to the outpatient
Right.
offices for OBGYN. And now a number of other departments, including our own, are following this model. So for the peritonsillar abscess, for the epistaxis, all this stuff, we've been asked to set up our offices so we can handle this in the office and keep that patient out of the ED.
So you're doing that after hours as well?
It's not clear how this is going to take shape. We
Yeah.
just started sort of laying this out today.
Yeah.
I think it makes sense. Now that you say it like that, like a peritonsillar abscess doesn't need to sit in the ED with COVID people.
Right.
Yeah, I mean, it's tricky, right? Because there is the occasional epistaxis that is going to go south and the office is the wrong place for it, right? But, the reality is that we're about to get so buried that nobody can possibly anticipate everything ahead of time. And we're all going to be calling audibles left and right.
Yeah. Michael, other topics or questions?
There's a specific question. The penetrance of this problem is variable, and some communities aren't feeling it. And the question to Lucian and Milan is, what's your on that?
Mike, that didn't come through clearly. Could you repeat that?
So the question is, for areas in the country that aren't as affected, what's your recommendation in terms of adherence to all of this? There's variable adherence to the specific things that you guys are doing.
Go ahead if you want to, Lucian, or I can go
Yeah,
first.
I mean, my perspective here is that I couldn't have imagined 5 days ago being where we are now, and I couldn't have imagined 5 days before that being where we were in 5 days, and on and on and on like that. It is not possible to start preparing too early. It is not possible to start preparing too thoroughly. However much you prepare, it will not be enough. Okay, so I don't know how that influences your practice, but this thing will move faster than you can imagine when you reach critical mass.
Yeah, I would echo that. What I would say is that if I look back a week or 2 weeks, I'm sitting here thinking I was an idiot. Why was I not doing this?
Right.
Why was I touching a laryngoscope without a glove? Why was I touching a patient without a glove? Why was I carrying the laryngoscope this way? Why was I not wearing a mask?
Why did I even see that patient?
Why did I even see that patient? Why did I operate on that patient? I mean, I'm lucky that I didn't contract it, but I probably in this day and age absolutely would contract that. So why would I do something different when I know going backwards or going forward that's what I would have done?
I think that not to dissuade people from getting ready, and not to dissuade and not to downplay any of this issue, but I think some of it may depend upon what the endemic risk is there. But I think the bottom line, it's going to come, and at some point in time, you are going to face this, and you need to be ready. And like Lucian said, it's never too late to get all that stuff and your ducks in order now.
Yeah, and I think none of us are really saying that it doesn't mean that you shouldn't take care of patients. But the very simple things that you can do that you may not be thinking of right now, and 2 weeks from now, you're going to be, well, I was an idiot. Why wasn't I doing that? You should prepare for those now.
Mm-hmm.
I mean, I think one thing, like some places probably still, when they sterilize their laryngoscopes, may immerse only the tip into a vat of Sidex. You know, this conversation would occur like a couple years ago. Someone would argue, you know, that's what we've done all along, and they've never had any problems with that. I think again, in this day and age, the story is different.
Yeah.
It should be full immersion of your scopes into bactericidal fluid.
Right. So I'm just going to rattle off a list of things, and you tell me if there's any situation in which you think that any of that needs to carry forth at this time, right? So trach changes, TEP changes, Botox
Trach changes, yes. And specifically, we've been asked to change cuffless to cuffed.
I apologize, I wasn't clear enough. The changing of cuffed to cuffless, okay, but what about like your patient that has a long-standing trach and they're due for their 3 month, right? Not that time. Okay, yeah. Botox patients, papilloma patients. How about?
So Botox is super interesting. If there's one group of patients that I've had a ton of pushback from when I tell them not to come to the office, it's the Botox patients. And I think I've talked to a number of colleagues, and I think that's a common experience, that our Botox patients are really, really insistent on getting their voices back.
Are you doing them? I mean, should we still do them? And if you would, clearly you would wear PPE. Would you change anything about the way that you're doing it? Because sometimes, you know, you tickle the airway, they cough, right?
I think you have to assume that they're going to cough. I think, you know, a couple of thoughts that I've had is maybe I'm not going to be injecting anybody over 60. I just don't want them in this environment. And if I do it, I'm going to be N95ing, face shield, gown, gloves. It's hard, right? Because you're going to be burning through a lot of equipment to treat a dozen patients. And that equipment is really valuable to people who are trying to save lives. So I think on balance, probably not.
Yeah, I haven't really changed my practice yet. Last week or 2 weeks ago, I injected some Botox patients, but I've been trying to get them to delay as much as possible. That being said, you know, what we've thought about essentially is putting masks on them if they do cough, and then of course you're wearing your full PPE. But it's a tough group to have a conversation with, because they just are so adamant, not in a bad way. I mean, I think that it really does affect their quality of life on a day-to-day basis. But
I'm very sympathetic to their predicament, you know, especially if they're going to be locked in their apartment and relying on phone for communication.
Yeah. All right. We are nearing to the end of the hour, but I have been told we can extend over a little bit if we need to. Michael, are there pressing other issues, topics, or questions that people want us to bring up?
A very intriguing question. What do you think laryngology is going to look like in 2021?
So we had talked about, I talked about this with my partner, and I think in the end, you know, laryngology boils right back down to laryngoscopy. So, you know, all this talk about potentially just switching to telemedicine within laryngology, I just don't think that's going to last. I mean, maybe as a screening tool or whatever, but ultimately, to make a proper diagnosis, we got to look in the larynx, and it's going to look pretty much the same as what it looked like, I think, before. Maybe more gloves and masks.
Mm-hmm.
Yeah, this is transient, which is not to minimize it in the least. Okay, it's the next 18 months are going to be ugly as heck. But when this is mastered, you know, being a physician is still a face-to-face enterprise, and being a laryngologist still requires looking at the vocal folds.
I think we're going to be much more higher in terms of our awareness of PPE that's probably required in this scenario. I think it's going to depend upon also what that epidemiology curve is going to look like. Right now we're in that spike. If we can get control of that spike, will we before we get a vaccine or medicines, then we're going to have to be trying to be in that zone where the number of people that are get infected doesn't increase, go beyond the number that get cured. And so we have to stay at that R level, that R1, they call it. And if there's still that endemic risk, we're going to have to really make sure that we continue to use good PPE, maybe not N95, but we really need to have great, strict requirements of how we handle things in our clinic.
Yeah. All right, well, I want to be mindful of everyone's time. So just to wrap up, I want to say thank you, first of all, to the panelists. Thank you also to Michael, and thank you to all of you out there who have been contributing the questions, the answers, the commentary. We really appreciate this as a first step, right, in an ongoing conversation about all of this. I'm sure that conversations will continue on EBT, and I encourage everybody to use that platform so we can continue to connect with each other and learn from each other as we address all of this. My last message to everybody is just to stay safe, wash your hands. You know, I'm hearing more that the social distance really isn't such a nice term because we should still keep connected to one another. I would say we're all in this together, and until that day when we can actually do this again, this is my last thought for everybody. Just want to say again, thank you all very much for your time tonight.
Thank you, VyVy.
Thank you.
All right.